So let me move on to the more challenging part of this, which is, so stigma exists. Somebody tells me I have a mental illness. I have this stereotype of what mental illness is supposed to look like. Am I going to believe what the person tells me? Well, of course not. I'm nothing like that. I'm nothing like that stereotype. So there's a natural tendency to reject the notion that you have any kind of a psychiatric disorder. But once you accept it, unfortunately you're accepting it into the same brain that has the imprint of the stereotype. So those two things have to exist, coexist in your mind, that I have a mental illness, and mental illness is this awful thing that makes me worthless and unpredictable and unable to function. So as a result, I become much less capable in those areas of life than I was before, because I'm telling myself the whole time I'm incapable and worthless and I can't function. And so I become more withdrawn from people and I become more dependent. I got into this whole area because I was trying to understand why it was when I was early in my career that when people understood they had a mental illness, they didn't necessarily do that much better than people who denied they had a mental illness. I could see examples of people who denied they had a mental illness doing well, and the opposite of people who accepted it and did not do well. So I could actually see this, I thought, happening, that people would get more withdrawn and dependent when they were given this diagnosis. So this thing we call insight can lead to poor outcome unless somehow you can get rid of this notion that you're worthless and incapable. And somehow in the process you can regain a sense of competence and power. So we're talking here about essentially three interwoven things: stigma and the stereotype of mental illness, accepting or not accepting the diagnosis, which you might call insight, and regaining your sense of power or empowerment through rejecting that notice, that label. So back in the 80s, three of us here in Boulder, Dawn Taylor, anybody know Dawn Taylor, who was a colleague, and Moira Powers, and I did some research on this topic with a series of people who were not acutely mentally ill. They were in treatment long term for psychotic illness, and we used these three measures. Did the person accept that they had a mental illness, or did they deny it, reject it? Did they have what psychologists call an internal locus of control? That is, they feel that they controlled their lives, that's an internal locus of control, or they were being controlled by everybody else around them, that's an external locus of control. So an internal locus of control is feeling empowered to have mastery over your own life. And outcome, and we looked at outcome. We actually looked at outcome in terms of what you might have expected outcome to be and what it actually turned out to be. So what we found was that if you had an acceptance of mental illness and an internal locus of control, you had good outcome. However, acceptance of the mental illness was associated with an external locus of control. So there weren't many people who had a sense of empowerment and accepted the label of mental illness. And the external locus of control is always associated with poor outcome, as you could imagine. We also found in that study that people who accepted they had an illness and had the greatest sense of internalized stigma had the worst self-esteem and the weakest empowerment sense. So if you carry around with you this sense of internalized stigma, you're really going to not have a very good outcome from the illness. So you have to, when we're working with people with serious mental illness, we have to both, yes, talk about whether a person has a mental illness or not, but also talk about what that means, and does it mean that you're worthless? principle over the years is actually not to talk that much about whether somebody has the mental illness, because there's no point in hammering people over the head with that without doing something about whether they feel they can manage their own lives. So that was a study done back in the 80s. It was about 20 years ahead of its time, because just recently there's been a lot more studies of this very constellation. With the recovery movement, we've got a lot of interest in empowerment, and people immediately started seeing how stigma was wrapped up in it. So here's just one study done in 2007, 75 people with schizophrenia, and they divided the groups of people they studied based on these sorts of measures into three. The high insight, the second group, high insight with low internalized stigma, that is, people who accepted they had an illness but could shake off their stereotype, had the highest functioning. On the other hand, people who had insight, accepted the label, but had a great sense of internalized stigma, had the worst outcome, hopeless and low self-esteem. So this is essentially the same result that we found. And now there have been many, many studies along these lines. And here's a review of those studies. That there's that self-stigma or internalized stigma is strongly negatively associated with hope, self-esteem, and empowerment. So if you have a high level of self-stigma, you're going to be hopeless, have low self-esteem, and feel disempowered. Self-stigma is also negatively associated with complying with treatment, and it's associated with a greater level of symptoms. So that's basically the whole thrust of what I've been leading up to. Is it's not much COP that's working with insight. We really have to help the person feel empowered, and we can start looking at how people can become empowered. One approach is to actually give the person more say in his or her treatment. So, for example, in the choice of medications, not many psychiatrists will do this, but hopefully we're moving more towards having the person select from a series of choices what medication will be better for depression or for psychotic symptoms, based both on the effect of medicine and the side effects. And so people who, we use the term service users in Britain, people with mental illness could make decisions about the medication based on these sorts of side effects. And they did a study of this in Verona, another one in Holland and elsewhere, where they took transcripts of the first outpatient consultation of somebody with a psychiatric disorder with a psychiatrist. And this was in a very good system in Verona. It's one of the best in the country. And they made minimal attempts to involve patients in treatment decision making. Well, Italy has got a fairly paternalistic medical system, so that wasn't a big surprise, but the same result was found also in Holland. Another way to try and empower our clients is to give them opportunities to become peer supporters and provide that support through peers during the acute treatment phase. And this sounds like a novel and interesting idea, but in fact it was first put out by one of the movers and shakers of the moral management era 200 and something years ago, when the York Retreat was being developed and when Pinel was striking the chains off the inmates of the Biquet Asylum. It was Jean-Baptiste Toussaint who says that the staff that he uses in the hospital where he was working in Paris are chosen from the category of mental patients. They are better suited to this demanding work because they are usually more gentle, honest and humane and disposed to kindness. So it was recognized then and now that by taking people who have experienced serious mental illness and employing them within the services, then you get people who radiate a different kind of empathy. And here's a list of the advantages that accrue when peer staff are used in providing services: engaging people in services more, that's engaging clients better, reducing the use of emergency rooms in hospitals, reducing substance use, reducing symptoms of depression and psychosis, increasing hope, self-control, and self-care, and the capacity to affect life change and quality of life and community inclusion. So all of those things have been shown by a series of studies to be true. So that's the summary. So that's the presentation. We did it in fast order, so we've got lots of time now for discussion.